record this. All right, here we go. Okay, slideshow. All right, welcome everyone to tonight's presentation on Oxandrolone, also known as Anavar. I'm presenting it for chronic disease prevention and management. Athletes have long used this as a performance enhancer to grow muscle. They've been using this probably since the 1970s. It was originally created in the 1965s. But there has been some clinical application for this, which we're going to get into in detail here. But it hasn't been used much mainstream, which is why I'm presenting this case to educate everyone on how to potentially apply this for difficult cases. Now, I'm going to present two cases that I've have personally experienced the benefits of this. So this is a patient, she's 59 years old. She had progressively worsening asthma over the course of 5 years, to the point where albuterol was worthless to her, Montelukast didn't work. She was sucking down budesonide multiple times a day just so that she could breathe. She would wake up multiple times throughout the night, unable to breathe and panicking because of this, of course. We tried various things. I tried thymosin alpha-1. We tried improving diet. We tried hormone replacement, estrogen, testosterone. Nothing was really working. And so based off my research of Oxandrolone, I decided to start this for her, and she noticed rapid improvement within 2 weeks. I talked to her today. This is now almost a month on this, and she no longer has this severe asthma. So here's another case I had. This is a lady. She was wasting from Epstein-Barr virus, 69-year-old female, cachectic, very frail, low muscle. She had no appetite. She couldn't eat. She's doing IV ozone to try to manage this EBV, but still not gaining weight. I started her on Oxandrolone 10 milligram troche, and she rapidly started gaining her appetite back, gained 11 pounds, which was fantastic for her, able to build some muscle mass. She actually stopped it, and she noticed that her weight started to keep coming on. We monitored some basic labs for her, no problems with livers. So why did I use Oxandrolone for this patient with severe asthma? So one of my theories was, well, it does have some similarity to the steroid molecule. And then I look at the literature and I'm finding that, it's been used to treat angioedema. And if we understand some of the mechanism for why asthma might be very problematic, it's bradykinin. And bradykinin asthma, it causes a lot of inflammation. So the Oxandrolone, what it does is it's highly bioavailable orally. So you can take it orally. It rapidly increases serum concentration within about an hour. It exits the body in about 8 hours. So potentially half-life is kind of rapid, about 8 hours. On drugs.com, they describe it as being used for weight loss. They describe it being used for wasting following administration of prolonged corticosteroids. It helps people gain their weight back, helps people with chronic infections, so potentially bacterial wounds, maybe long-term viruses, as we're going to see later in the studies, trauma, as we're going to see as well. Pharmacodynamics and metabolism. So the anabolic androgenic steroids, specifically Oxandrolone, is I'm going to show you later, it has low toxicity to the liver. It's highly bioavailable in the serum. Some of the history on this, it was kind of fell out of favor after the 1970s because of the use by the bodybuilder community, but then it came back on the market in the 90s and started researching how it can help patients with severe trauma and wasting conditions. Oxandrolone, it modulates some inflammatory pathways. This study was done on mice. They burned the mice, and then they monitored how oxandrolone can modulate multiple inflammatory cytokines associated with the burn of the mice. And if we understand how asthma and some inflammatory diseases work, these are diseases of high cytokine activation. So if we can modulate that with a medicine that's not as harmful as corticosteroids and potentially have many beneficial effects for patients with wasting diseases, we may understand how oxandrolone can be very powerful. So this is where it's been studied a lot, is in wasting conditions. This study done by Singh et al. 2004. They were wanting to see if it had androgenic or viralizing activity, because that was one question Dr. Halasa had, is, do we have viralizing activity with the oxandrolone? And the answer is no. For the most part, not. It's not like testosterone. This is a DHT derivative. So you can get some problems with acne where you can get oil on the skin, but it's not classically androgenizing like testosterone would be. It also has no effect on estrogen. This was a study in burnt individuals. And what they did here is they monitored the hormones of besides oxandrolone. So they measured IGF-1, they measured growth hormone, estradiol, and testosterone. While testosterone was suppressed, well, it will increase testosterone initially, but long-term, it can potentially suppress it. It had no effect on the estrogen. Let's see, we skipped here. So this is some approvals by the FDA. They approve it for trauma, severe illness, diseases of wasting, AIDS, HIV, and patients with cachectic conditions related to COPD, cystic fibrosis. And mostly in burns. So it's been used, I think it's still used in the US for burns extensively, based off multiple meta-analysis of how oxandrolone helps in burn wounds. So this is a really good PDF I can send anyone if they're interested, kind of a summary of all the literature in 1999 and before. And so we're going to go through some of these, showing how patients with immobilization, you can give them the oxandrolone and they will retain their muscle mass, even if they're not exercising. But if they start exercising, doing some physical therapy, the benefits of muscle mass retention is leaps and bounds better than oxandrolone alone. Now, these patients given oxandrolone for burn wounds, they exit the hospital quicker, quicker recovery, less surgical complications, quicker healing of the wounds. This study was very interesting. It was a VA study, patients with severe alcoholic hepatitis. So AST is 400, crazy high. You'd never think give them an anabolic steroid, but that's exactly what this study did, and extraordinary doses of 40 to 80 milligrams in these severe hepatitis. And what they showed is that there was no worsening of the hepatitis. They didn't die of the liver failure. How do I go back? They didn't die of liver failure from giving them oxandrolone. They actually got better. They retained better muscle mass. Their ASTs actually improved. Their body weight improved. So that was quite cool to see. Berger et al. Showed that patients given oxandrolone through 16-week period, 5 milligrams, so very mild dose, they maintained their weight gain. So this was in HIV/AIDS patients, wasting conditions. They increased their body weight, their albumin improved, their quality of life improved, their viral load decreased. There was no hepatic dysfunction. This one is a very interesting neuromuscular disorders, Duchenne's, ALS, myositis. Again, no hepatic dysfunctions were noted with these. All these patients, they increased their body weight, their muscle strength improved. Their functional status improved in these wasting conditions. So there have been some reports of hepatic dysfunction, but these are in patients who are using other agents as well. Bodybuilders using other anabolic steroids, which are well known to cause liver injury. Also, intense physical activity, intense training, as the bodybuilder will do, will also cause liver enzyme elevations, but it's not necessarily a sign of liver injury. This is something I always tell my patients when we're checking labs. Just don't train super hard before you test labs. I mean, some of these guys, they don't listen. So other studies on spinal cord injury, body composition improved, body weight improved. Lovejoy et al. Was a very cool study. Oxandrolone decreased subcutaneous abdominal fat more than testosterone enanthate or weight loss alone, and also tended to produce favorable changes in visceral fat. We know visceral fat is attributed to multiple disease states, cardiovascular disease, increased cytokine activation in COVID-19. So oxandrolone here was very helpful in reducing the visceral fat, reducing triglycerides as well. There are some lipid abnormalities that you'll see with oxandrolone, namely the reduction of HDL and slight increase of the LDL. But notably, the triglyceride reduction, I think that's most important to note if we're taking all lipid particles into consideration, triglycerides probably being the one that's most atherogenic. Doyle et al., 47 patients with hyperlipidemia. The drug induced a rapid and persisting fall of plasma triglycerides exceeding 50 to 100 in one half of the patients. About 1/3 of the patients had falls in serum cholesterol levels. No serious side effects developed in a period of 7-month treatment. So it is concluded that the drug may be helpful in reducing serum triglycerides. So that's kind of counterintuitive to what we understand about anabolic steroids, the lipid abnormalities. I think this might be attributed towards greater muscle mass, right? We know that greater muscle mass improves insulin sensitivity, reduces the metabolic syndrome. This is also interesting. Elderly with arterial sclerosis and multiple chronic diseases, these researchers were ballsy enough to use an anabolic steroid for these patients in 1967. I don't think they do that in this day and age, not politically correct. But their cholesterol reduces, their serum triglyceride reduced, transient hepatic dysfunction. But we always see it again and again. We'll see here the hepatic dysfunction is very transient in oxandrolone usage. So oxandrolone inhibits muscle catabolism by working as a glucocorticoid receptor antagonist. Oxandrolone has high anabolic activity compared to testosterone and methyltestosterone with a ratio of anabolic and androgenic of 10-to-1, which is incredible. A 10-to-1 ratio for anabolic properties. So providers using long-term glucocorticoids, seeing their patients waste away, they should really consider oxandrolone because we know how terrible All right, I'm back. I don't know what that was. I'm going to go back to sharing my screen here. So this is interesting. Oxandrolone treatment in hereditary angioedema. So this has been one of the classic treatments for hereditary angioedema in the old days was oxandrolone. And it's associated with significant clinical and laboratory evidence of therapeutic effect in this pubertal boy. I actually have heard about this from some older practitioners who would use oxandrolone for angioedema and chronic urticaria back in the 90s. Some older practitioners, maybe some of you guys have used this before. Let's talk about some pediatric burn studies here, oxandrolone in the kids who got burnt. Again, ballsy studies using an anabolic steroid in pediatrics, infants of all sort of children. We know that the burn victims, they lose muscle, they lose albumin, it's hyperinflammatory, their catabolism. A lot of these patients they die in the hospital from the effects of the burns. So oxandrolone has been one of the proven treatments for severe burns, doubling muscle strength significantly compared to controls. We talked about this a little bit.
Let me just add something, because those are something that's very important to be answered.
Sure.
Is this drug is working on testosterone receptors or not? Because if it does, then how come it does not have virilizing effect on females, and it does not interfere with the gonads of the male and causing infertility? So there is something about the mechanism of action. It's a little bit different from regular testosterone, and that's what we need to know exactly where the difference is.
Yes.
If it's possible, if you can come up with that.
Yeah, I think I'll have a little bit more on that particular side effect at the end here. So this is interesting. High-dose oxandrolone therapy was employed in a patient population with pre-existing severe liver injury. No complications attributed to its use were observed. It confers a resistance to liver metabolism as well as marked anabolic activity. In addition, oxandrolone appears not to exhibit the serious hepatotoxic effects attributed to conventional anabolic steroids. Talk about safety. Let's see. Williams et al. Reported that loss to lean body mass will lead to immune dysfunction of 10%, delayed when hitting 20% systemic infections.
We cannot hear you, Dr. Stefan.
Basically, the rate of lean mass in post-burn recovery is 4 times higher than that in placebo group or nutrition alone group, with no significant complications. They monitor liver enzymes in the burn unit as well, transient elevations. Let's see. So this is a study. They're looking at 5-year outcomes after long-term oxandrolone administration in severely burned children. This was done in 2016. They monitored their height velocity. So apparently, I didn't know this, but burnt children, because I don't work with burnt children, they don't grow. Oxandrolone was given to these children, and the children given oxandrolone, they grow better. Their bones, they grow significantly more than control groups. Liver function was assessed as well as IGF-1, haptoglobin, etc. No real problems with the livers there. So, does oxandrolone shut down natural testosterone? So this was a 5-day study, and they showed that, yes, it does lower testosterone. If you look at Lewin et al., which is a fantastic book here, I have it on my table. Lewin et al.'s Anabolics. He reviews some of the studies, and he also agrees that, yes, it does lower testosterone and can shut down natural production in men. So conventional or bodybuilders will use a testosterone base when they're using oxandrolone to negate this problem. But the interesting thing is that this drug has been used so extensively in children and pediatrics. I haven't really seen much discussion in the pediatric burn studies on oxandrolone's suppressive effect on children. So that's unclear to me whether these children have problems later on in life with fertility, or do they need to do post-cycle therapy. I guess the issue is just the main concern there with burn children is getting them to survive the hospital admission. Enhanced protein synthesis with oxandrolone. This is what we have discussed extensively. So we know that during the fasted state, protein breakdown is normally much higher than protein synthesis. Despite being fasted, all subjects had an increased utilization of amino acids as outward transport decreased 28% after oxandrolone treatment. We further showed a 65% increase in the efficiency of protein synthesis with oxandrolone. So it's interesting. The protein you're going to eat is just going to be used much more rapidly in the oxandrolone groups, or the patients you give them oxandrolone, give them some protein.
Does it increase the appetite?
Yes.
Does it increase the appetite or okay?
It
So
does.
this will not be good for weight loss. This is
No,
good for
it's
weight gain.
weight gain and building muscle. Yeah. So not a weight loss drug at all. No. So there's a lot of details about the proposed mechanism here about sarcopenia. I won't get into that too much, but sarcopenia.
Okay, so are you okay?
Yeah, I'm back.
Is it connection?
Connection issue.
Okay.
Doesn't want me to talk about sarcopenia. Yeah, sarcopenia, a wasting disease associated with multiple disease comorbidities. The aging process alone, frailty, fractures, less resilience to disease. My practice is to optimize muscle in my patients to make them more resistant to disease, testosterone, peptides, etc. Oxandrolone seems to be another thing we can use as well. Let's see. So that's my kind of summary on oxandrolone. Have you guys ever used it yourself? Maybe even back in the 90s when it was more used for urticaria, angioedema, etc.? No one has experience with this one?
I never heard about it. I thought all the synthetic testosterones are they are good for building muscles, but they do have a lot of side effects. That's why we don't use it. But it seems like this drug does not interfere with liver metabolism. I mean, does not inhibit the P450, you know, that enzyme. So there's things that's very unique about this anabolic steroid.
Yeah, I'd say this one is quite unique compared to any of the other ones because it's so readily available orally. It's safe on the liver. It's been studied in quite frail populations with no adverse effects, no increased death, and better survival rate. So that's why this interests me so much.
Explain how that patient with systemic lupus erythematosus with that big disc, how
Yeah.
it's been improved in this case. What exactly have done? What's the mechanism here? I mean, I know it's have anti-inflammatory effect,
Yeah.
but
We will
why it's
see.
so
We're
powerful?
using it. I'm using it for this patient because she is wasting. She has used steroids and has some of the wasting condition associated with that. I'm hoping that by off chance it can help her condition. It remains to be seen. I had never seen asthma. No literature, nothing I read on the internet ever said that oxandrolone could help with asthma. And here I have a case of a patient with 5 years severe asthma, essentially cured with oxandrolone. And I didn't use it for that. I used it because she was wasting, and potentially could help based off some mechanisms I maybe understood. I'm surprised that this drug has not been studied more in more disease states.
Yeah, it's a very interesting drug. We need to figure out more about its effect on AMPK, for example. That's very important, whether it's stimulate or inhibit the AMPK, because that has to do with metabolic syndrome. Um, you know, so those things we still need to know more about the mechanism of action to predict what exactly we expect from it. I mean, what about the inhibition of interleukin 6 and Th17? How good inhibition of this specific the cytokines? So you know, if we can dig more detail about the mechanism of action, we can even have even better production. But as you said, it does help. It does decrease testosterone. So it's like any other anabolic, just you know, just the anabolic steroids.
Yeah.
But what is good about this drug is for using it for cancer patients who are wasting, because that's where the problem we have. My father also has cachexia from cancer, and the only thing you can give is Marinol, you know, the drug that's like it's a form of CBD, marijuana, you know. But you know, this drug will be better in treating cachexia of cancer. I think it's very promising.
Why can't your dad take testosterone?
No, we're not at that time. I don't have any drug in front of us that helps to increase the or help to reverse cachexia except Marinol.
Oh,
And that's the only thing we know, but it causes constipation.
no,
But now
give him
with
testosterone, give him Oxandrolone. He will come back from wasting.
well, he passed away, so I'm just
Ah,
saying the past.
sorry
This
to
is
hear.
like 3 years ago. But you know, that's what we are learning here. We're coming up with some solutions that in the past it was a challenge.
Yeah,
So I appreciate that you come up with some answers for cachexia for cancer, for example. That's a big problem, and
huge
there
problem.
is no, we don't have anything in front of us except Marinol, which is a form of marijuana
Yeah.
extracts and that ones. That's the only thing I know that's powerful to increase the appetite. And there's
Not
many
only
other
that, Dr.
patients.
Halasa, but according to what he said, that it helps the bone pain. In osteoporotic patient, if it helps the bone pain, then in cancer patient, it should help the bone pain too, with those with the bone metastasis and cachexia. So I think I'm going to go home and office and try that.
Yeah.
But where do you order it from, the Trosh?
Yeah, you can get an account with South Lake Pharmacy. They're in Zephyr Hills, Florida. They have a Troche and they have a capsule version of it.
Well, Mike Beamer doesn't have it.
I don't think my Bimmer does that. No.
Well, ask him to do it. We need him to do it because he's supporting this platform.
Okay.
Did you call him? Did you ask him, or it's difficult to do it, or what?
No, I'll contact him about it.
Oh yeah, please, because I think we need to encourage people who are supporting this platform and help their business. But anyway, whatever the source is, I think, as Dr. Patel said, we don't have an answer for cachexia and bone loss and a lot of things. You provide that answer. So, but again, can we use it for females and chronic use? With that
It's
go?
actually among the bodybuilder community, it's known as the woman's steroid, right? Because it
Okay.
has, yeah, it's known as the woman's steroid because it has so low viralizing effect.
Okay, so that's we need to know the explanation, because if it works on testosterone, right, most of the time if it works on testosterone receptor, it has a virilization syndrome or virilizing effect. So why this one does not have that virilizing effect? So we need to know more explanation to distinguish this from regular anabolic steroids, and that's where I think you can do more homework there, where you can show why it's the difference, why it's a women testosterone versus the others. So there must be something more deeper in the chemistry there.
Yeah. Sure.
So what about in the patients, those who have a problem, the elderly particularly, those who have a gait problem, balance problem, then also the neurological diseases where they have a muscle problem. Have you ever tried in those patients?
I've used it in the patients with the wasting from chronic EBV and low appetite, and I used it in the patient with the chronic steroid, the corticosteroid use. They didn't have like neuromuscular; they just had overall weakness and degeneration from long-term illness.
Do you think that it would help the patients with the neuromuscular muscle
Correct.
weakness?
If I can pull up the slides again, it's been studied in Duchenne's muscular dystrophy and ALS and spinal cord paralysis. And all these patients, they do better with gaining their muscle mass back and their healing of the wounds quicker.
They get the strength.
The strength.
Yeah.
Yeah, but the strength, if muscle mass increases and if they don't have a strength or endurance, then it's of no use.
It increases the strength of the burn victims, their grip strength, with or without exercise.
But the burned victims do not have a neurological problem.
No.
They are loaded with all the inflammatory cytokines, and inflammatory cytokines can make your muscle very, very weak, like we see in COVID patients. Okay, post-COVID syndrome patients, when are long haulers, they have a muscle weakness.
Yeah. Let me see if I can pull this page up for you. Yeah, this is the spinal cord injury studies, their body composition. Let's see, complete healing of non-healing pressure ulcers in 89% of patients, increasing body weight. Let's see. Let's see, what else do we have here? Whole body isometric strength increased and upper body isometric strength increased.
But what kind of patients were they?
Spinal cord. This one was body inclusion body myositis.
Okay. So
Yeah.
that is an inflammatory muscle disease.
Yeah.
And where they have a tremendous degree of muscle pain and muscle weakness, they cannot squat.
Oof.
These patients with the inclusion body myositis. So, and it was given 10 milligram twice a day.
Yeah.
For 3 months. So you said it takes about 2 weeks before you know that it helps.
Yeah, at least in my patient with the asthma, it took 2 weeks to get the asthma under control.
But what about the muscle weakness and?
Yeah, it took about 2 to 3 weeks of patient to get her appetite back and her strength starting to come back.
And what about the osteoporotic patients with the bone pain?
I'm gonna start trying that in osteoporotic patients.
Do you think it is advisable to use in a early, like a patient from when it goes from the osteopenia to osteoporosis?
Yes.
At the time, if you start them early enough, that it would help. It just helps the muscle mass. It doesn't help the bone, increased density, correct?
It does. If you look, if we understand the how the pediatrics, where's that pediatric study? Their bone mass, their height increased on the Oxandrolone group. They grew like 50% more than the non-treated group.
But that may be the activity on their plate. Okay, so that's where the growth occurs. If they where they open plate and it grows from there. So I'm not too sure if we can compare, because in osteoporosis there is imbalance between the osteoclastic and osteoblastic activity.
Yeah, I still resort to just old school estradiol and testosterone for these females. They usually do pretty well. What's your experience with that?
Okay, so you think it works on the same axis?
Well, I would start with basic testosterone and estradiol. Usually that's good enough to improve their bone density. I haven't seen much study oxandrolone in osteoporosis in women. I have to look for that. I didn't see that.
Yeah, but it would not help the pain. Whether
Probably not. Depends where their pain is from. Is it from a tissue weakness?
Well, it's a inflammation. Because when the osteoclastic activity occurs and it is unregulated, unchecked, of course it will happen. The inflammatory cytokines will go up, and as a result, so.
I think as a combination, if you add to this amloxanox, KPV, and then you add to it oxytocin and things that we're doing, as a combination, I think it would help to navigate every, all those gaps, because amloxanox helps to simulate osteoporosis as well. I mean, it reverses osteoporosis. So with this low doses, even if you said 10 milligram a day, and if you're using it for anti-aging, can you do it like 5 milligram on daily use for people above 50 to gain strength and muscles without affecting its the testosterone, the endogenous testosterone, and the sexual performance?
Yeah, for those patients, they'd probably already be on a testosterone base at that age and that frailty, and then oxandrolone would be in addition to that.
Right. So it's kind of, if you it fills up the gap. I mean,
So
I can
Dr.
see.
Patel, drugs.com actually says that that's for relief of bone pain frequently accompanying osteoporosis. I'm not sure.
I know. I saw that before.
I'm not sure where they get that.
In one of your previous slides. That's why I said that. And then it doesn't talk anything about mental acuity. Because if you give testosterone, it just works on the body, but it works on the brain too.
Yeah, it would. There wasn't much studies. There's like one very bad study on mental effects. There not much comment on mental health with this. Yeah, the way it might work for the bone, because we know the glucocorticoids, when we give them to patients, their bones waste. This thing actually is a competitive inhibitor of the glucocorticoid receptor.
Well, if it works on testosterone itself receptors stimulate the reverse osteoporosis, just like a second hormone.
Yeah.
Right. So it's like estrogen and testosterone out there. Both of them helps in if they work as an analog to testosterone. But again, this drug is very unique in terms of does not have virilizing effect of testosterone, does not have much of liver problems, so it does not inhibit those those enzymes of the liver. And so I think if you mix it with amloxanox, KBV, oxytocin, methylene blue, and you add all these things in a cocktail, I think you can get all the gaps and the side effects and the weakness, all of those things that can be filled out with the things that we're doing in the combination. That's how I can see it. Better way of giving it as a multi-therapy.
Yeah, I agree. It's not available commercially anymore. It went away a long time ago. We can only get it from rare compounding pharmacies who are brave enough to make this, because it has such a taboo against it because the bodybuilders use it. So no one wants to prescribe it. No one wants to carry it, but it's an amazing drug in my opinion.
How much does it cost, Stefan?
$6 a day.
10 milligram or 15 milligram or how much?
Like a 20-30 milligram tablet will cost you like $6 a day.
Okay. And you can break the tablet or no?
It comes in a capsule, actually. I misspoke. It comes in a capsule. Can't break it. It comes in a lozenge form. Really, it comes like a gel lozenge. Can't break that either. So hard to reduce the cost on it.
If it is in capsule, you can.
Could, yeah, in a capsule you could. Yeah, you can prescribe it. It was South Lake Pharmacy. They have like 100 milligram capsules, and I think their price for that is pretty reasonable. It's like $10 for a capsule. So you could totally like split that up. But
is it water soluble?
No, it's fat soluble.
Fat soluble. Okay.
Best taken with fat.
Okay.
And you have to be careful if you're talking about opening a capsule and using part of the powder, because there are other things in there, as you know, fillers, binders, all that kind of stuff, and they're not always homogeneous. So you have to be very careful when you open a capsule and use a partial dose.
Okay, very good. This you said South Lake Pharmacy, right?
Yeah.
So Dr. Quinn, try this. Let's see if you try it and see if it will help increase your muscle more than what we see now on the camera.
Yeah, no, I'm gonna go to the Diana ball. Remember that one?
No.
Now, oral 5 milligram tablets that the bodybuilders just went crazy on. They dumped the Anavar and went to the Diana ball. But I do want to roll back real fast, Dr. Halasa, and say something about the Marinol. Marinol is synthetic THC. There's no CBD in it. And the problem, it came out during the war on drugs or whatever, because they wanted to have a proprietary product where people wouldn't use marijuana. So they came up with this thing. And the problem is, like anything else, it's an isolate and it doesn't work the way whole plants do. And what people found was, instead of causing euphoria, it caused dysphoria. So most of the people absolutely flatly quit using Marinol. I don't know what's going on nowadays, but this was back in the 80s and 90s where they just said, nope, no thanks. Makes me feel terrible. Now, it was supposed to be to stimulate appetite, but if it did that, then that's good. But otherwise, people felt terrible taking it.
Well, it causes constipation as another side effect of it. So I think this is better option for cachexia, because again, we don't have any answer for cachexia, for cancer especially. And I think this is the answer for it. Because what they have, the mainstream medicine, is Marinol. That's it. They don't have anything. I know, because I've been there.
No, exactly.
And this will be an option.
Exactly. Now, do you think that by eating small amounts, if these people can do that, you know more than I, if they can do that to stimulate mTOR, to build muscle and tissue strength, just to make sure that we're not in a state of autophagy?
Well, I'm just saying, those patients with cancer, they secrete chemicals. The cancer itself secretes chemicals that is suppressing completely the appetite, right? It's part of protection against kind of defend way to fight cancer, but it's too much excessively to the point patients are losing weight like crazy.
Yeah.
Just increasing up, you really need to have something strong
Well,
to
this sounds
reverse
like
this.
this sounds like what Stefan said. This sounds like a pretty good option in people like that. If you're able to get it, that's that's always a problem, and it'd be great for Dr. Beamer to weigh in on that, because sometimes
I don't know why, Stefan, why you did not, but Beamer did not weigh on this.
He's not here in the lecture.
Hey, this is the first lecture for you.
Yeah, I found.
Well, you're gonna have another lecture with Dr. William. He's here still.
Yeah, Clearfield's there.
You want to steal him, Dr. William? I'm gonna sell Dr. Stefan for you for 1,000.
There's another drug.
Yeah, I'll take them.
Okay.
Gentlemen, there's another drug that is very good for cachexia. It had its moment in the sun in the 1980s when it was being promoted widely by general media, actually, Penthouse magazine. Guccione, his wife, had cancer, and she was improved greatly by this drug. It was from a Dr. Goldstein, I believe, or something like that. Dr. Goldstein. It was it was a component of rocket fuel. It was hydroxy something or other, and this stuff was amazingly good at reversing cachexia.
Wow.
I mean,
what's
amazing.
The name of it?
Began with an H. It was a hydroxy something or other. It was a component of rocket fuel. The doctor's name was Dr. Golden, something like Golden or Goldman. And if you look a little bit, you'll be able to find it. There was a lot of controversy, and the FDA came down on this guy, and there were lawsuits flying left and right. And it had its day in the sun. And then, of course, like all good things, the powers that be exhaust the Crusaders, and then it just disappeared.
Got it.
Oh,
I think they got this one too.
Yeah, I'll try and find it online, but it was around the 1980s, and it was literally a component of rocket fuel.
Jeez.
And this guy used it in hundreds of patients with very good results. The media was very positive towards it. but then it just kind of disappeared into obscurity.
Could it be hydrazine?
It might have been hydrazine. Who was the doctor who was promoting it?
I'm going to look and try to find that.
Hydrazine is antihistamine, right? No.
No. It was something like hydrazine. It may not have been hydrazine.
This is not hydroxyzine. This is hydrazine.
No, not hydroxyzine. No.
Right. No, Dr. Halasa said it antihistamine.
Oh.
So I'm telling him what is the difference.
Gotcha.
Good. I have answer for you, Halasa, why it's not so virilizing. So the Lewin, this is from Lewin's book, and the low androgenic activity of oxandrolone is due in part to it being a derivative of DHT. This creates a less androgenic steroid because the agent lacks the capacity to interact with the 5-alpha reductase enzyme and convert to a more potent dihydral form.
Will it understand what I ask?
This is
Okay. Now, that's a good one. So that's very important in your lecture, because this will show it doesn't have much of virilizing effect. So
right.
You're minimizing that, which is a good thing.
Right. So yeah.
Now we need to know its effect on AMPK. That would be good if we know it. I think it's effect on mTOR, AMPK. Those two enzymes are very critical because it has to do with metabolic syndrome.
The question is, what year were those discovered?
Right.
Because this is an old drug, and the research and a lot of.
Well, that's the reason I think you, when you do the lecture with Dr. William Clearfield, because we want to show that it does have a favorable metabolic effect, means it lowers the sugar, it lowers the fat, the fatty acids, and it helps in atherosclerosis and things like that. So we need to see if it's have any effect on AMPK. Now, it does increase the anabolic protein synthesis. That's a good thing for cachexia. I think it's a drug of choice. But we want to see if there's any side effects of it. Does it increase glucose? I mean, does it? But you said it's good for diabetic. But how? What's the mechanism? It's good for diabetic and lowering the sugar, for example. Things like those are, those questions. And if it does not have any effect or does increase the glucose, then it's better to be combined with other drugs that will help to lower the sugar. So in a certain way, we can combine it in a way that we can get the best out of it.
That comes back to my lecture on muscle-centric medicine, why you want to pull the lever of creating more muscle to reverse all these disease states. And if we have a drug that can increase the muscle, you're going to see a reduction in all of the other diseases.
Well, that's one of the mechanisms. If you increase the muscle mass, okay, you lower the sugar because then you have enough tissue to absorb sugar.
Yeah.
So that's why people, when they're exercising and they build muscles, the sugar drops.
Yeah.
And if you don't exercise and you don't move and all that stuff, definitely there is no place for the sugar to go. So, but all these things, it's good to have a clear understanding, because especially AMPK and mTOR, those two enzymes, we need to know the effect of it. But as an anti-inflammatory, it works like steroids. It may have the COX and LOX and NOX enzymes. I can see that this drug does that like steroids and help to dump the inflammation, tips interleukin-6. We want to see how severe and if there's any articles of that. But this will be a drug of choice for cachexia. I think it's most of the patients of cancer die from cachexia. I mean, I can relate to it because of my father himself. One of the problems that we have is how to reverse the cachexia. And whatever they eat, but it's not showing up in their muscles. It's just the cancer secretes chemicals that just breaks down muscles and bones.
Yeah.
How about giving creatinine with this so to help the muscle mass?
Creatine? Yeah. I do it for all my patients. Creatine is fantastic.
And what do you use the creatinine? I thought that you need to use also the carnitine, and you need to use also the DHA and
A branched chain amino acid, a whey protein supplement, creatine. These will all be fantastic for the cachectic patient. Yeah.
And in the cancer patients, can we not combine an almost fully ketogenic diet to get rid of the glucose that the cancer cells are absorbing? Because they can't live on fat. They have to live on glucose and glutamine, actually. I think we can limit that. And then Stefan, doesn't the creatine cause the muscles to retain water?
Yes.
So I think a combination of all these things could be helpful.
Oh, yeah.
Yeah, it's one of my most recommended supplements is the creatine.
Well, here's the thing. When my dad had cancer and he stopped taking sugar at all, zero. Well, that's good and bad. Yes, you're starving the cancer, but those cancers also can modify themselves and start even surviving with fat. So, it's just those cancer cells are very smart, intelligent ones. But I think a combination of all of this, it may help to diffuse those cancer skills and compromise them. But you need to really have this answer. I mean, cancer. It has many things. You need to work on the fibrosis. They need to work on the platelets, the clotting. You need to work on the metabolic, yes, and lowering the sugar. You need to work on the immune system and shifting it to Th1. You need to work on the cancer themselves and start destroying them with whether chemotherapy or radiotherapy or anything like that. That helps to break them up. So it's with multiple effects, but still we are missing the cachexia part. So I think this lecture is adding something very valuable here in cancer. I think Dr. Patel seeing a lot of patients with cancer, and I think there's a struggle there with cachexia.
Good. Well, I'll be interested to hear your reports on this. Let me know what you guys learned from this. As I said, there's nothing in the literature and nothing on the internet regarding asthma and oxandrolone, but lo and behold, this case of improvement in asthma is quite impressive.
Gentlemen, hydralazine sulfate was the drug.
Sulfate.
Yeah, exactly.
Hydralazine sulfate.
That's
It was very popular up through 2015 or so, and then it went black.
okay. Is that a Presaline?
I do not know.
Oh, yeah, because they used to use that for blood pressure.
This could, it's possible. This was originally a component of rocket fuel.
Wow.
And this Dr. Goldstein or Goldman or something like that discovered it and was a big advocate for it for many years until he just was exhausted, and then he dropped out of it. But it supposedly was miraculous for cachexia.
Right.
I wonder if we could still get it.
Well, you may not be able to get it as a drug, but I mean, the substance is still there because they're still making rocket fuel.
Well, yeah, it was called a Presaline, again, for high blood pressure and heart failure. So maybe it's around.
Was that nitrofurantoin or nitro?
No, that's macrodantin.
Macrodan, yeah. Okay, well, yeah, possibly. Anyway, that's all I know is that there was a big to do about it, and supposedly it worked. And I spoke with some people who had some personal experience with it, who were true believers. So I hope I hope that might be of help for you if you want to look any further.
We can't get it anymore, can we?
Well, we don't know that. We don't know that. Sometimes, what you can't get in the United States, you can easily get in Mexico or other parts of the world. They're a little more civilized and humanistic.
Yeah, wow. They used it in combination with Isordil. Wow.
All right. Well, been a long day at the office for me. I'm going to close up shop here, and I'll give this lecture again to Bill Clearfield maybe at some point when I have more patient data on this. I'm going to try it on some more patients I can think of.
Well, thank you. It was an excellent presentation. I'm very interested in learning more. Good night and God bless you all.
Night, guys.
Okay, good night, everybody. I'll be in the United States tomorrow, heading from Germany. So see you.
Dr.
Safe
Halasa,
trip.
Yeah,
Dr. Halasa, when you get off the line, could you call me, please?
I will.
Thank you.
Good night, everyone.
Good night.
Bye-bye.